Good morning, good afternoon, and good evening. Welcome to the series of laryngology webinars hosted by Mangeshkar Hospital in Pune in India and also by Baird Brandon Baird in University of Chicago. I'm your moderator. My name is Vincent Oswald, and I've been an ENT surgeon for over 60 years. So we're very fortunate to have the experts to give us their viewpoint of a particular topic every 3 months. And today's topic is dysplasia or leukoplakia. Let me introduce you Brandon. Brandon is a laryngology surgeon specializing in wide range of laryngeal diseases with an emphasis on medical and surgical management of voice and swallowing disorders. He completed the residency in otolaryngology at Stanford University and fellowship at Harvard University and Massachusetts General Hospital. He has spearheaded the office-based laryngology practice at the University of Chicago. His research interests include adjuvant therapy for early diagnosis of glottic cancer and laryngeal dysplasia. We're also fortunate to have Sarah Rappaport as a faculty. She is an assistant professor in otolaryngology and head and neck surgery at Georgetown University Hospital and a laryngologist at the Washington, D.C. Veterans Affairs Medical Center. She completed her laryngology fellowship at Mount Sinai Hospital in New York City under the mentorship of well-known Dr. Mark Courtney and Peik Wu. I met both these surgeons in Paris some time ago. I was faculty there, where they were faculty as well. So her current research of interest include gender affirming voice care, vocal fold paresis and paralysis, and minimally invasive office-based treatments for vocal fold lesions and scars. And then we have another participant who is Dr. Rakesh Srivastava, who is a practicing ENT surgeon in the north of India in a place called Lucknow. And he pursued his career in medicine from 1991 and became a consultant surgeon about 29 years ago, he tells me. And he has been governing body members of AI of India and a secretary and president of Laryngology and Voice Association and a fellow of Medellin Academy, otolaryngology head and neck surgeon. So he has also authored a book on Atlas on narrowband imaging in upper air-adjusted registered tract lesions. So we have these three participants, and of course our host. Our host is in Pune is Dr. Sachin Gandhi. Now Sachin Gandhi is well known for his expertise in all sorts of laryngeal disorders. Uh, I was part of his department in developing in early part of the century. And I think I would be right to say that is one of the leading laryngology department in anywhere in the world. So we have these experts to ask questions. First of all, we will have their presentation, and then we'll follow that with panel discussion. We have invited questions from the audience, and those will be tackled first, and then I'll ask the panel discussion. I'll ask each member on certain topics to give more practical viewpoint rather than theoretical, because there's a lot of theory. It's everywhere on the internet, so it's not very important. But practical information is what we're seeking for. So I think we should make a start. Brandon, are you ready?
Yes, and thank you so much again, Dr. Oswald, for the introduction. And for those tuning in, thank you for joining us again this month. So I'm going to talk about broad strokes here. We're going to talk about laryngeal leukoplakia and then more specifically dysplasia. I want to thank again Dr. Gandhi and Dr. Oswald for having me. And so today, as you've heard that we're discussing laryngeal leukoplakia, leukoplakia in the larynx and its treatment has evolved over the past decade or two. However, despite recent advances in both our ability to diagnose and also treat this entity, there's still a number of sort of areas of controversy and disagreement about how things should be addressed. And that's why I'm looking forward to the rich discussion that we'll have after we talk today. For the first part of this lecture, I'm going to talk about sort of setting the stage for the subsequent presentations that will come later. So this was mostly review and basic pathophysiology, as well as diagnosis. We're going to start with a standard definition of leukoplakia, presenting features, etiology, classification systems that exist, as well as histopathological grades. Briefly touch on diagnosis, although a lot of this will be expounded upon by my colleague, Dr. Rappaport, who's going to follow. And then closing with considerations to include when you're discussing leukoplakia with your patients. So what is leukoplakia? Quite literally, it means white patch. It's derived from the Greek leukos and plate, which is a white plate. There are a number of reasons why patients develop leukoplakia. And it's very important to realize that leukoplakia is a descriptive term. It is not necessarily a diagnostic term. So when you're seeing a patient that has leukoplakia, you want to get down to sort of what the appropriate diagnosis is. An appropriate initial diagnosis is vital. All diagnoses rely primarily on biopsy ultimately. However, there are some red herrings, like fungal laryngitis, that you can consider attempts at medical management first that might be similar to a dysplasia. What's important as you're attempting to evaluate a biopsy from a pathological perspective is to ensure that you have a biopsy that's representative of the most concerning area of the lesion. And additionally, it's vital that you take a deep enough biopsy to have adequate assessment of the presence and/or absence of invasion. So this is really important on your first biopsy of the lesion, as recurrent disease can somewhat be elusive and also difficult to manage if you suspect that you may have accidentally understaged or undergraded your initial lesion. So now regarding leukoplakia, there are roughly 4.2 presenting patients per 100,000 people that have leukoplakia. There are higher incidence of leukoplakia in men than in women, and most people that present with leukoplakia are in their 6th decade of life or later. Over time, the risk stratification between laryngeal dysplasia and/or leukoplakia and squamous cell carcinoma is more apparent. And that tends to happen about 10 to 15 years older than that median age of incidence, so in the 7th or 8th decades of life. The most common sites of leukoplakia are along the superior and the medial edge of the midmembranous fold. In most cases present with unilateral lesions, although bilateral lesions are not unheard of. So leukoplaskia is usually one of the following: benign keratosis, mild to moderate dysplasia, severe dysplasia, and/or carcinoma in situ or CIS, or laryngeal cancer. We'll focus now on dysplasia. And dysplasia is basically a precancerous change at the cellular level. And we'll talk a little bit about the histopathologic findings in a bit. Regarding keratosis, it's oftentimes that there can be a number of explanations for a diagnosis of benign keratosis. In most cases, it's an inadequate biopsy. That's the reason for the diagnosis of keratosis. As you all know, the vocal fold epithelium is inherently thin and transparent. So anything that is translucent and/or opaque is suspicious for at least epithelial thickening, if not possibly keratosis sort of forming. And for suspected keratoses, a biopsy is indicated. Treatment to address disease, prevent progression, and improve the pliability slash closure of the fold itself should be strongly considered. As we know that the keratosis tends to be firm and have rheologic properties that are oftentimes different than normal epithelium. And Dr. Gandhi will speak a little bit more about treatment there. So a step up from benign keratosis is dysplasia. Dr. Rappaport will talk about the stroboscopic findings, but just briefly on white light laryngoscopy, you'll oftentimes see erythema of the cord. You'll sometimes see leukoplakia, as we've discussed before. You'll sometimes see some exophytic components to the appearance of the cord. And the vascularity is really the big thing to focus on. As you can see here, you have normal arborization patterns here of the vasculature, and that gets sort of disrupted here. Same thing here, arborization patterns that are somewhat normal that get disrupted, and that sort of is your first sign that there's something that's going on there that's more than just epithelial thickening. There might be a dysplasia. So I'm looking at this figure A on the left-hand side. This is representative of low-grade dysplasia. What you can see is there's hyperplastic epithelium with increased basal-type cells, very mild atypia, and most of it's occupying the lower sort of half of the epithelium there. This next picture shows high-grade dysplasia, and what you'll notice is there's more hyperplastic epithelium with increased basal-type cells, and almost an entirely sort of involving the entire thickness of the epithelium, this sort of abnormal atypical process with preserved polarity. What we'll see in this slide is carcinoma in situ, and these patients with the carcinoma in situ can start to really present with some pliability properties that are abnormal, as well as problems with closure and premature contact between the two sides. On histopathology, we tend to see a lot of parakeratotic findings. We see hyperplastic epithelium again, with pronounced architectural and cellular abnormalities, as well as severe nuclear changes in atypia, and it's occupying typically the entire thickness of the epithelium without penetrating deep into the stroma. So regarding the rate of dysplasia in patients that present with leukoplakia, many biopsies demonstrate at least mild or moderate dysplasia. This is about 33% of those that were evaluated in a meta-analysis, and about 15% show severe dysplasia or CIS. When it comes to diagnostic sort of comparison, I consider severe dysplasia and CIS to be relatively similar, and then I kind of lump them into their similar category. And then I lump mild to moderate into a similar category, and we'll get kind of to why that is and sort of the newer classification system that sort of support that. Of people with a biopsy of benign keratosis, about 4% of those patients go on to develop squamous cell carcinoma over time. That again speaks to the fact that any benign keratosis is probably likely representative of an underlying dysplastic process that's going on, and the diagnosis of benign keratosis is more likely an inadequate biopsy than an actual, at least in my experience, than an actual separate process. As keratosis should not exist on the vocal folds based on how the epithelium is oriented and created. About 10% of those with mild to moderate dysplasia develop SCC over the years, and about 18.1% with severe dysplasia develop SCC over the years. Work is being done to identify unique molecular markers that can help to prognosticate the risk of malignant transformation, such as the Hippo pathway, which is being implicated. But work is still being done to help understand what dysplastic lesions are more concerning for development into SCC and which are not. So how do these patients usually present? An overwhelming majority of these patients present with dysphonia. A select number of patients may also have discomfort and or dysphagia / aspiration, depending on the exophytic nature and the size of the lesion. Diagnosis will be further elaborated upon later, but all patients, after completing a thorough history and physical, should undergo stroboscopy. I prefer flexible stroboscopy, given its ability to assess sort of more distally, subglottic, as well as the inferior edge of the true vocal fold, which can help with your operative planning. And so what are the reasons that one develops dysplasia? So smoking and alcohol exposure are the major risk factors found in about 75% of cases. But this process is a multi-year, multi-step, and multipath progressive disease that we see, and it typically involves cumulative genetic damage. Other implicated concepts include immune evasion, epigenetic changes, and genetic changes that contribute to this. We also know that there are some occupational factors and exposures that have been implicated. People that work with chemicals or caustic fumes tend to have a higher rate of developing dysplasia and or carcinoma. And there's been a question over the past decade, what's the role of HPV in the development of dysplasia, especially in patients that are younger than the sort of standard age of 60? So looking at HPV and laryngeal dysplasia, we know that smoking and alcohol use are known risk factors, but with HPV, there's a little bit more debate. Most of the relationship between HPV and dysplasia is seen in patients with RRP, recurrent respiratory papillomatosis. And there is some debate about the true nature of HPV and its role in carcinogenesis in patients with laryngeal dysplasia. And we're all aware of the high and the low grade dysplasia that can be found in RRP with an incidence between 0 and 83% of cases. But when looking at HPV via either in situ hybridization or PCR in 15 and 30 laryngeal dysplasia samples respectively, we don't see that many of them are positive for HPV DNA. So long story short, there's not really a good consensus, and there aren't great studies to evaluate the role of HPV in dysplasia, but it seems like signs are pointing to it not necessarily being a factor, but still jury's out. So looking at the histopathological classification of leukoplakic lesions and specifically laryngeal dysplasia, this has gone through a kind of circuitous kind of route to get to where we are today. Mild, moderate, and severe were noted in early WHO classification schemes. Other descriptive terms such as squamous and intraepithelial neoplasm and intraepithelial lesion have been used previously, but many of these methods were heavily influenced by the grading system that's used for cervical cancer and cervical CIN, et cetera, where dysplasia extends from the basal level to the surface, in which there is really no keratotic sort of keratinization that we see in the larynx. So those nomenclatures have fallen out of favor because they don't always sort of classify what we're seeing in the way that it needs to be classified. Current nomenclature falls mostly within a binary scale, as is indicated by the WHO 2017 system, where we identify things that are low grade and identify things that are high grade, and then also can use potentially carcinoma in situ as sort of the next step up from there. However, there's some inconsistency in the grading system among pathologists. Published papers on inter-observer agreement have often suggested that dysplasia grading in itself is inaccurate and limited and have limited clinical value. This negative impression arises mostly through the use of Kappa statistics, which are relatively inappropriate for grading along a continuum. Using this analysis for dysplasia grading, it's almost impossible to prove that, moderate dysplasia, moderate agreement between pathologists. So that's why the WHO sort of recommended keeping this sort of binary system. There are a number of practical problems that make assessment of dysplasia and carcinoma risk in the larynx difficult. As I mentioned previously, there are issues with sampling errors because the most histologic changes do not occur in the red or thickened keratotic areas up here. Sampling to adequate depth is a particular problem when keratin is thick and when the basal cell layers of the epithelium may be more than 2 millimeters below the surface. There are confusing variations in the normal microscopic anatomy of the cords, and epithelial thickness is variable from as few as 5 cells to 20 cells in thickness in different places, which causes inconsistency in the grading and terms that are noted. There's also a complex transition between respiratory and squamous epithelium and occasionally glands within the cords, whose ducts can undergo metaplastic changes, as well as changes from inflammation due to reflux, as well as candidal infection and radiation from previous cancer treatment can really complicate the histological picture. So finally, just kind of wrapping up with how do we discuss these disorders and diseases with patients when they get diagnosed with them? It's really important to remind them that dysplasia is a highly recurrent process in some patients. Recurrent disease carries the propensity to treat and sometimes overtreat the underlying normal tissue and superficial lamina propria. And that's a big thing. The more you have to treat the normal native tissue, the more at risk you put the patient's voice in terms of generating scar and other issues. Decision to move forward towards intervention should be considered carefully, and you want to mitigate potential contributing risk factors. So patients that are diagnosed with dysplasia, what are things that you can do, such as quitting smoking to prevent it from recurring? You want to discuss with the patients the risk of postponing intervention and potentially risking progression of disease, or proceeding with ablation and potentially risking scar. It's a two-way conversation, and really requires sort of your professional commitment to the patient. So finally, in conclusion, just to review, leukoplakia, descriptive term, dysplasia is a diagnosis, it occurs mostly in men, older age smokers, and people that have occupational exposure. Diagnosis is based on stroboscopy, biopsy. This can be done either in the office or via SML, suspension microlaryngoscopy. Histopathology is now sort of settled on the WHO classification with low grade and high grade. And it's important when you're discussing with your patients to emphasize the recurrent nature of the disease, as well as what sort of implications it has on intervention versus observation. So thank you again for your attention today, and we'll kind of go on to the next step now. Dr. Oswald, you're muted. Dr. Oswald, you're muted, I think.
It has got its own mind, you know. It just changes as it wants. Can you hear me now?
Yes.
Yeah, okay. So Sarah is going to tell us about the importance of laryngoscopy in the diagnosis of dysplasia. Thank you, Sarah.
Of course, of course. Can you hear me okay?
Yes.
Can you? Okay.
Yeah.
Well, good morning, good afternoon, good evening. As Dr. Oswald said, it's really wonderful that we can all be in such different parts of the world and yet communicating and studying and discussing this topic together. It's something I'm passionate about. So for those of you who don't know me, I'm Sarah Rappaport. I'm a laryngologist here in Washington, D.C. And today I'm going to use really a case-based process of talking about the role of stroboscopy. And I think it can play a very important role in understanding what you're looking at when you see something like a leukoplakic lesion on the vocal fold. So let's just jump right in. So, you know, after the next 10 minutes, I'm really hoping that I can help the audience feel more comfortable articulating answers to when and why is stroboscopy clinically indicated in cases of glottic leukoplakia? You know, and what is the data behind how stroboscopy impacts clinical decision-making and patient outcomes? And more specifically, I want to clarify this information for the more clinically ambiguous patients. And by that, I mean not the singer with a vocal fold hemorrhage or a teacher with a polyp, where you might really understand the clinical scenario, how the patient ended up in your office and what you're looking at, but rather the patients whose clinical presentations are more immediately concerning or confusing. And I think that's relevant for all of us because I think that there's a distinct technique to understanding what we're looking at when we look at stroboscopy. And I think it can really be an ally to us in diagnosis, in particular for leukoplakia when we're obviously worrying about dysplasia or, God forbid, something worse. So one fact I cannot stress enough in this conversation is that equipment quality matters when you're visualizing the larynx for dysphonia. And I want to prove that to you. And it's important to incorporate high quality equipment to help us make the correct diagnosis. So, you know, ideally you're using stroboscopy because of the high definition image it's providing you. And sometimes it's hard to have that in your clinic, and that's okay. I just think it's important to know the limitations of what you're looking at so that you can know the limitations of the diagnosis that you can provide or the diagnostic information you can provide when you're looking at someone's laryngeal exam. So a skeptic who says to me, does the image quality of your scope actually make a difference in patient care and guiding patient diagnosis? To that person, I always want to show them the following two images that I'm going to share with you. And this image that you're looking at now is an example from a flexible fiber optic endoscope. And, you know, common equipment seen in a general ENT's practice. And this is an example of a rigid stroboscopy. And here is the both side by side. This plays, excuse me. I want to show you, hang on. So this is an image of patient 1. This is his rigid stroboscopy, same patient, same day, different scope. On this exam, take a look at what you see, and I'll play it twice if you need it. Let's look one more time. Same patient, different scope. One is a flexible, just standard image, and the other is an actual stroboscopy. And did you see a lesion on this first image? Because I did not. I didn't see a lesion. Maybe now that I've looked at this patient and I see that there's something irregular here on the anterior inferior left vocal fold, maybe I can tell myself I'm seeing something here on this initial image, but the truth is that I didn't see anything on the first image. And both images are taken from the same patient at the same visit. The lesion's not visible on the first exam, so you can't really make a diagnosis with the information that you have based on that exam. It's much more obvious in the second exam. You can tell that there's a cyst on that medial left true vocal fold. Maybe it's a mucus retention cyst. But all the images I'm going to show you for the rest of the presentation, just so that you can familiarize yourself with what I'm using for my equipment, are distal chip flexible endoscopes or rigid endoscope, and all have stroboscopy when relevant. So with that context of kind of equipment that we're using, I want to jump into some clinical cases and use that to really guide an understanding of the utility and the data behind why stroboscopy can help us and how it's relevant. So in this first clinical case, this is a 6-year-old male. He's a non-smoker, and he presents after referral from his primary care doctor for progressive throat clearing and dysphonia. He's had no prior workup to this point. No one has examined his larynx before. His general head and neck exam is unremarkable. And so, of course, he comes to me and I'm going to look at his larynx. But in, what do you think that, I mean, obviously this is a topic of stroboscopy, so maybe I'm getting ahead of myself, but obviously the next thing that I'm going to do is I'm going to use stroboscopy. And, the really important thing to remember about stroboscopy is it's not actually a video. It's basically a series of images that are being brought together in kind of a flip book type situation. And it's capturing moments of movement of the vocal folds to slow them down so that we can really understand what it is we're looking at, because the vocal folds move too quickly for us to be able to actually perceive the motion of the vocal fold. And so what you're seeing with vibration when you're looking at the motion of the vocal fold under stroboscopy is that you're seeing the cover of the vocal fold, or the epithelium and superficial lamina propria, vibrating over the body of the vocal fold, which is the thyroarytenoid muscle. So if something is tacking the cover down to the muscle, such as an invasive lesion, that's going to affect the vocal fold's ability to vibrate, but it's not the only thing that can affect the vocal fold's ability to vibrate. And so I want us to keep that in mind, and we'll come back to that shortly. But when I'm looking at a lesion when I'm looking at a stroboscopy and I'm concerned about a lesion, my focus is not just the quality of the lesion, which obviously matters, but also how is it affecting the vibration? And that's where stroboscopy can really provide insight into what you're looking at. So this is that gentleman's stroboscopy. Let's take a look at it. So what is it that I'm seeing here? I'm seeing there's a lot of detail on this exam. I'm seeing that the left true vocal fold has a heaped up leukoplakic lesion. But if you look very closely, you'll see that actually the vocal fold underneath that lesion is vibrating pretty well. In fact, it's vibrating pretty symmetrically compared to the right side. Let's look again. you can almost see that the vocal fold underneath this very otherwise scary looking lesion, because it's a big white lesion that's occupying almost the entire left true vocal fold. It's the vocal fold itself seems like it's vibrating and almost moving in a very similar symmetric way to the contralateral side. And so does it matter that we did stroboscopy for that patient? And the answer is that stroboscopy is really helpful from a sensitivity, but not a specificity standpoint. So, so when the mucosal wave and amplitude of the vibration of the vocal fold are normal on a stroboscopy, no matter what the lesion is, the exam is highly sensitive for ruling out malignancy. So think of how much information you might have just gained on that exam when it demonstrated a very scary looking leukoplakic lesion, in that there's this huge white lesion and suddenly you're starting to worry, what can that be? What can this mean? But meanwhile, you understand that the vocal fold underneath the lesion is still moving, it's still vibrating. It's a very reassuring exam, but it's not very specific information at all. So if you've lost your mucosal wave or your amplitude of that vocal fold, it's very hard for you to be able to tell a patient that you know what you're looking at. So while I feel very reassured about the exam that I just showed you, if that vocal fold weren't moving, my reassurance would plummet, but my ability to also tell the patient what I'm looking at would not necessarily be very specific. There could be scarring underneath the lesion in the vocal fold. There could be so much heaped keratosis on top of the vocal fold that it's causing the vocal fold to lose its vibratory parameters. And so the information that you can get from a stroboscopy like the one I just showed you is not specific, although it is sensitive. And it's important to know that that helps you guide the patient in terms of saying, I see something that looks like not such a troubling scenario, and here's why. It's highly unlikely that it's an invasive cancer. Here's why. The vibration of your vocal fold is still intact. It isn't going deep into the vocal fold. It's superficial, even though it's exophytic. So this meta-analysis by Malum et al., it includes 9 studies, several hundred patients, and they found that this data, is really quite impressive and consistent. And so I use this data frequently in clinic when I'm helping to guide patients and discuss exam findings with them. It also guides my management. So in this way, stroboscopy really helps me stratify concern for patient lesions, especially in cases of leukoplakia, because leukoplakia, like Dr. Baird said, it's a very vague finding. It just means a white lesion, and it can carry a great array of concern. So to be able to generate, to decrease that concern and understand in a little bit more detail what we're looking at, I think is really critical. And that's where stroboscopy can be such a helpful tool, because like Dr. Baird said, leukoplakia has no pathologic correlation. It's purely a clinical descriptor. It tells us that we're looking at a white plaque, a white lesion. And when you see a leukoplakic lesion, what you're essentially seeing is, like Dr. Baird said, you're seeing keratin-forming cells where they shouldn't be, where you wouldn't expect them. You should have no keratinizing squamous epithelium covering the true vocal folds, but suddenly keratin is there. Or it could be some infectious process causing you to have the appearance of keratin on the vocal folds. But when you see that keratin, that could be dysplasia, could be carcinoma, could be pure keratosis, or it could be what one of my mentors likes to call a head fake. It's actually neither. It could be some sort of infectious process. And so the challenge that all of us have, what we have in common with one another, is that it really brings us to realize that the challenge in looking at leukoplakia is that undertreatment of these disease processes can allow for disease progression, causing unnecessary morbidity in our patients, whereas overtreatment or prematurely aggressive biopsy or resection of a leukoplakic lesion can lead to loss of vocal quality, which is very hard to give back to a patient if we've taken it away, even inadvertently. And so I think it's worthwhile to understand that while the role of stroboscopy can play in helping to determine a plane of resection for a lesion in clinic based on your stroboscopy exam is very, very helpful. Because any preoperative planning that you can do before you go to the operating room, I think is helpful. It guides you, it sets you up for success, as well as the patient in terms of their expectations. So for context and just brief review, when you're talking about resections of dysplastic laryngeal lesions, and especially malignant lesions, we use the European laryngeal Laryngologic Society, or ELS, classification system. And I'm only going to touch briefly on the first two types, because I think you rarely need to go beyond that for dysplasia or carcinoma in situ. But to briefly review, an ELS type 1 resection involves a subepithelial resection, which means that you're taking the epithelium and the superficial lamina propria, versus an ELS type 2 resection, where you're actually taking the vocal ligament and leaving the vocalis muscle bare. And in ELS type 3 and 4, in the ELS type 3, you're going into the muscle itself, and then in ELS type 4, you're actually taking the whole vocal fold. So stroboscopy really plays a preoperative role in counseling, because for a leukoplakic lesion, for you to be able to tell a patient, I'm gonna I can leave the epithelial layer intact, I'm going to just try and remove something very superficial, or I'm going down to the level of the ligament and I'm taking the epithelium and the superficial lamina propria, the outcomes for that patient in terms of voice quality are really very different. But, you have to prioritize oncologic resection, obviously, for patients where you're worried about something more concerning, more malignant. So a paper that I found very instructive that helps me when I'm trying to resect a de novo lesion is this paper written by Peretti et al., where they looked at patients' preoperative stroboscopies and their saline infusion in the operating room to try to assess how deep a resection they should make in the operating room. And so patients who had normal video stroboscopy and normal saline infusion got a subepithelial resection, and patients who had either one abnormal, one or the other, or both, underwent a subligamentous resection. And for patients who had undergone previous biopsy, all bets were off, and they went straight to the muscle and took a piece of the muscle. So they went transmuscular. And what Peretti and his colleagues found is that with this protocol was that they only undertreated one patient, but they did overtreat 13 of the patients. And of the 10 of those patients were in the previous biopsy group. So what I drew from the study is that you're usually not going to go wrong if patients have a normal stroboscopy and saline infusion, if you do an ELS type 1 resection. But this technique of going into the muscle just because they had a previous biopsy is maybe not necessary. And that's really helpful to know, because as a laryngologist, I spent my training and now my clinical practice trying to preserve epithelium and superficial lamina propria. That is my goal whenever possible. So the idea that the lowest ranked oncologic resection involves taking the epithelium and almost, if not all, the superficial lamina propria is very scary to me. Because those are really, once you take that, you really can't give it back to the patient. So I really try to be cautious in terms of my preoperative workup with stroboscopy and preoperative patient counseling. And I really try to make sure that if I'm going to resect the epithelium and SLP, it's really, really necessary for the patient. So with that in mind, I want to look at a second case. So this is a former smoker. She had recently moved to Washington, D.C. from somewhere else. She was having increasing dysphonia to the point where now she would be nearly aphonic for days. Her father had been a smoker. He died of laryngeal cancer, and she shared that she'd previously seen an ENT for her voice, who told her that she had nodules, and she didn't pursue any treatment for her lesions because her voice improved for a short period after she saw that ENT. He may have given her some steroids. She couldn't remember. And of course, she brought no prior records with her from her prior ENT visit. She couldn't even remember that physician's name. So we were basically starting from scratch when she came to my office. And here is her voice exam at that initial presentation. Let me know if you can't hear me or you can't hear.
The spot is on the key again. The hard hit. Did he hit him? We were away a year ago. We eat eggs every Easter. Mama will make lemon muffins. Peter will keep at the peak.
So when I listen to her voice, I hear tremendous strain, severe strain. It almost sounds like the vocal folds aren't even vibrating. Maybe there's a little bit of breathiness, but really strain is the predominant takeaway that I'm hearing. Maybe there's a little bit of roughness. Here's her stroboscopy. So what I'm seeing here is that there are bilateral heaped keratotic lesions on the mid vocal folds bilaterally. What's wild to me is how her vocal folds are vibrating when she had so much strain when she was talking to me. And this is really a reminder that when you're looking at someone's exam and when you're doing a stroboscopy, take your time, help them relax, help them produce airflow. Sometimes when someone's speaking, they're just so strained, there's so much supraglottic extralaryngeal tension, but you can help them relax. You can take your time and really see if you can generate vibration of the vocal folds. Because remember, it's that vibration or lack of vibration that's really going to guide what you're looking at. So if I were just looking at a flexible scope with just a white light scope, no vibration, I'd see bilateral heaped up white lesions, leukoplakic lesions bilaterally, I'd be really concerned. But in this patient, I'm seeing that I can generate vibration, symmetric vibration in her vocal folds. And so while I am concerned about her exam, my degree of concern has diminished significantly. And what we ended up doing was we ended up putting her on an antifungal for 3 weeks. And I also, because of her history in terms of family history of bladder cancer and her concern for her leukoplakia, I did book her for an OR for a microdirect laryngoscopy and biopsy in the operating room after her follow-up visit with me. So about 5 weeks later, she had a date with me in the operating room, but I was bringing her back 3 weeks later after taking an oral systemic antifungal for 3 weeks to see if that would help make anything better. So this way, if it didn't make anything better, we had a plan for a biopsy. If it did make things better, you can always cancel a booked OR. And this is her at her exam 3 weeks later. Here's her voice.
The blue spot is on the key again. How hard did he hit him? We were away a year ago. We eat eggs every Easter. My mama makes lemon muffins. Peter will keep
Clear
at
voice.
the
If you met her in the supermarket, you'd never worry about her voice. And here is her exam. This is a rigid stroboscopy as opposed to before. You can see she still has pinpoint lesions remaining on those anterior vocal folds, but those heaped up leukoplakic plaques that we saw before, they're not there anymore. A very reassuring exam, right? I'm not worried about her anymore. And I had a plan, and my stroboscopy really helped me tier how significantly concerned to be and have a backup plan for her. And so with that, where I really want to leave us is that the most practical next step for any dysphonic patient, especially when dysphonia is not explained by a white light exam alone, is stroboscopy. So you're never wrong to do an initial just strobe without a flexible scope without stroboscopy. But if you do an exam and you don't have an explanation for their dysphonia, consider a stroboscopy. You can gain so much information from that because it can really serve as a guide for severity of disease and also help inform your depth of resection intraoperatively. And then I know one of my colleagues is going to talk about adjuncts that you can use for stroboscopy, like narrowband imaging. And I'd like you to keep stroboscopy in mind during that talk because there are adjuncts that you can add to stroboscopy that can really provide even further insight into your care for your patients. So thank you so much.
Yeah. Thank you, Sarah. And we should move on to my topic of surgical management of leukoplakia. Okay. We'll just go through the slides and few examples. We already know about what is leukoplakia, how to examine this, and what are the differentials. As far as surgical treatment is concerned, what are the aims of the surgery? The first surgical treatment, and of course, the point we face is recurrence, and when and how to operate for a recurrence. What are the various tools available for surgery? How much is the recurrence rate? How to avoid the recurrence? What we are really worried, and patient, of course, the relatives are worried about is it malignant? Is it cancerous? And is it going to be cancerous? So what are the chances? How to follow up a patient we have treated with surgery or medical line of treatment? And what is the role of immunohistochemistry, which is available in most of the institutes now, along with histopathological examination, which we are doing for each and every patient. We know about, we already heard from Brandon. So it's just the appearance and how much to excise, whether to excise, because if you go quite deep, could lead to dysphonia for the patient. And if he doesn't excise, then maybe it will progress to carcinoma. And we say we have just missed, and why we don't operate or never operated on this patient. So it's a tricky decision. Sarah has already talked about how to select the patient with the help of video laryngoscopy in detail. We know about this. It's hyperplasia, dysplasia, and carcinoma. A normal mucosa, a hyperplasia. Basically, there are excess of cells, but there is no atypia. When you start seeing atypia, it turns into dysplasia, right, from mild, moderate, and severe. And when we see the architectural distortion of stratification and actually the increasing number of mitosis, then it becomes severe dysplasia. And then the atypia, when it increases, it becomes carcinoma situ. When it breaks the basement membrane, then it becomes invasive carcinoma. This is the slide actually which I want to focus as far as the surgical treatment is concerned. This we all know the layers of the vocal fold, the epithelium, the lamina propria, the ligament, and the vocalis muscle. So as we see, this is the epithelium. Now, what's the thickness of the epithelium? So in any given adult larynx, it's around 0.5 millimeters. The lamina propria is thicker, around 1 millimeter, and the vocalis muscle again is 2 to 3 millimeters thick. Now, why this is important? Because leukoplakia is the disease or is the pathology affecting the superficial epithelium, and we have to concentrate on removing the lesion along with the superficial epithelium and not to invade or affect the superficial lamina propria below. Why? Because the epithelium can always regenerate and give back the mucosal waves, but the superficial lamina propria will not regenerate. The scarring we will be able to see after invading the superficial lamina propria, and the mucosal waves would get affected, affecting the phonatory outcome. This is just this slide I want to discuss about what are the differentials we see in our day-to-day practice. Patient showing on examination a feature like a whitish patches on both the vocal folds. having a history, maybe a short history, 3 to 6 months history, or maybe that uh, less than that, 1 or 2 months on antibiotics. And these whitish patches on both the vocal cords are always referred or diagnosed as leukoplakia. Whether to operate, what you have to look at is a short history, though the patches are there, which are quite similar to a leukoplakia. See the surrounding tissue. When there is a prominence of the blood vessel or a congestion surrounding the white patches, then it is acute laryngitis. So this is a patient we see quite commonly in our OPDs, and we do a stroboscopy or a laryngoscopy, and we see whitish patches on the both the vocal cords, see the surrounding tissue. And another diagnosis is, of course, the laryngeal candidiasis or laryngeal fungal infections. I don't know, the number has increased since the COVID pandemic, but this you have to keep in mind as one of the differential. What is the aim of the surgery? Number one, what patients and we are also not worried about is whether it's malignancy or not. So we have to rule out malignancy. Number two, vocal correction. So patient has come for dysphonia, you have to correct the dysphonia. And of course, prevent the recurrence, and then removal will always get rid of it getting transformed into a malignant lesion. So basically, a patient coming for follow-up showing reduced mucosal layer on a stroboscopy, you have to rule out malignancy, and that's why you go in for surgery. The second would be again correction of this dysphonia, and what precautions you have to take and watch for in follow-up is recurrence and malignant transformation. What are the tools available? The cold steel, mucosal stripping, not really practice these days because of worry to injure the superficial lamina propria below. CO2 laser is what we practice and gives the best of the results because it's limited to the superficial epithelium and gives the results comparable to a normal coronary outcome. There are new stream of lasers coming in laryngology. These are amniotic lasers, pulse KTP laser, and now blue laser are coming in the market in a big way. We are going to see in our clips. Now, if patient is unfit and there are frequent recurrences and patient, of course, has a positive history of smoking, and you have to anyway do the surgery again, then office-based procedures with fiber laser of KTP, blue laser, diode laser, or a CO2 laser would always have in office-based procedures. But this is a case of a leukoplakic patch on the left vocal fold. I have selected this patient for surgery because dysphonia is there for more than 6 months. There is a history of smoking and mucosal waves are reduced on initial laryngostroboscopy. I take the patient under microscopic setup. The first thing I do is I will examine the entire lesion with a 0 degrees laparoscope or a sinus endoscope, just to see the extent of the lesion anteroposterior. Then what I'm going to check with is take a 70 degrees sinus endoscope or a laparoscope and see whether the anterior commissure is free, the lateral extent into the ventricle, and the extent in the inferior surface of the vocal cord. Now, as you see with the 0 degrees, you see there is a patch which is on the middle and inferior surface of the vocal cord, and you have to excise these as well. So examination with 0 degrees endoscope and 70 degrees endoscope. You do have sinoscopes with you, so just take them and examine them without excising the lesion. Then you can do intraoperative NBI. Now you can see the normal blood vessels. So really the margin of excision you can define with the help of eye scan or NBI we do have with you during the surgery. You can see the blood vessels quite clear and here you can decide how much to excise. Then again hydrodissection, because it's going to separate the superficial lamina, superficial epithelium from the lamina propria, going to elevate the lesion. Then with the help of a CO2 laser, you have to just hold the lesion with smallest possible cup forceps. I use always the upturned cup forceps. Hold it close to the margin. And then first, what you do before excising, mark the incision, mark the borders of the excision. So this is a CO2 laser, acute blade. The depth of the CO2 laser which we are using is not more than 0.25 millimeters at one shot. So I'm not really worried about the deep thermal damage when I'm striking it around the lesion. Then I am excising the lesion all around the borders. You can see the cleavage now. It's a superficial epithelium. Absolutely no charring. And when, I mean, this is just a pharmaceutical principle. When you are operating the anterior commissure, don't injure the opposite vocal cord and the anterior commissure itself. Be away from it, the opposite vocal cord and the anterior commissure. So it will not result into the anterior web post surgery. Now see, this is the endoscope. This is the superficial lamina propria. I can see. You can just check. You have excised only the superficial epithelium and not gone into deep into the superficial lamina propria. This is with the 70 degrees endoscope. This is with the 0 degree endoscope. So margin seems to be, depth seems to be quite all right. This is the pre-op stroboscopy of the same patient. And see, this stroboscopy actually is done just 24 hours after the surgery, so next day, and you can see quite good mucosal waves, good approximation, good mucosal waves, and good vocal outcome. Now, that lesion was on the edge of the vocal fold. When the lesion is on the surface of the vocal fold, it's very difficult to hold it and excise it with CO2 laser. So these types of lesion, you can always use a KTP or blue laser. And how we use it? A KTP laser has to be used in a non-contact mode, keeping away the laser beam 2 to 3 millimeters away and then firing. So it will separate the pads from the ligament down or the superficial lamina down. And then once you vaporize it all along, then you can strip it with a neuropathy. keep it with the neuropathy. And just remove the pads with the forceps. We have to, because it was not separated with the application of the capillary laser, and it separates it from the basement line. You can see the lamina propria quite preserved. So basically, how it separates with a non-contact mode or a TTP laser application, separating from the underlying superficial lamina by rupturing the basement membrane because it has got proteins in it. Any patient with difficult exposure, again, you can use a KTP laser, pass it through a flexible laryngoscope. Same principle, non-contact mode, and then hold it with the forceps and take a biopsy. Now, histopathological examination again to check the degree of urticaria, whether it is just a leukoplakia or there are changes of dysplasia, whether it is mild, moderate, or severe. According to it, you can always follow up the patient. Now, what is the rate of malignant transformation? It's around 8 to 10% of all the patients with leukoplakia you diagnose and take a biopsy from. Similar to the experience which I have operating it for last almost 25 years. Now, grades of dysplasia correlated to the rate of malignant transformation. I mean, you have the first diagnosis was, let's say, there was no dysplasia, then the rate is much less. So it's around 4%. So patients who had biopsied with leukoplakia patches, so no dysplasia, then the rate is around 4%. And as they go from mild to moderate dysplasia, it increases to 10%, and severe dysplasia carcinoma and CT, it goes up to 18 to 20%. So initial diagnosis always is going to give you some idea what are the chances of malignant transformation. Accordingly, you can keep the patient under follow-up. How to follow up the patient? So what are the points which you should look at? We have already seen the histopathological grading, so initial report, morphology of the lesion. So if it's a single or multiple, it's on one vocal cord, it's on the bilateral vocal cords. It is a responder or non-responder. That means what are the recurrence rates or recurrence you can see on stroboscopy, which patient is going to follow up with maybe every 3 to 6 months. And of course, mucosal wave, when you see it on stroboscopy, that's going to give you idea whether to go in for invasive second surgery or not. So basically, I think the initial histopathological diagnosis, whether they are multicentric and the mucosal wave, is going to give you some idea about the follow-up and chances of recurrence and malignant transformation. So, I mean, what we follow, leukoplakia without dysplasia, annual follow-up, mild to moderate, every 3 months we follow with these patients with video laryngoscopy, NVI, which Dr. Rakesh is going to talk about. And when they are high risk, that means smoking, tobacco chewing, and alcohol, these factors are positive, then of course you can go in for PET scan every year. Severe dysplasia carcinoma and situ, I mean, of course, you have to treat them as T1 vocal cord carcinoma, and you can do type 1 chordectomy for these patients. If they are multifocal, present on both the vocal cords, same to this, then the patient is going in for radiation. What is the recurrence rate in leukoplakia among all the published studies? Around 20% of all the leukoplakic patients. Amongst this 20%, the disease progression was noted in 5% of all the patients. Now, recurrence rate, when they compared CO2 laser and KTP laser, and of course, I am doing both of these for many years. Recurrence rate really is the similar. Then how you, which laser you will go in for? So KTP laser basically for lesion on the superficial surface of the vocal cord, CO2 laser on the edge of the vocal fold, and KTP laser is going to give you, as you compare both of these methods, good phonological results or vocal results of the surgery. Now this we are started doing this for last almost 6-7 years is immunohistochemistry. So you just with histopathology in action, what are the chances of the patient, apart from the factors we already have seen, can we predict on histopathology or immunohistochemistry, what are the chances of malignant transformation? So these are biomarkers. These two biomarkers we do, P53 and Ki67. So if these factors are positive, then there is a chance of recurrence or maybe transformation into malignant lesions. These patients, when they show, any patient of leukoplakia who on immunohistochemistry shows these markers positive, then we keep them on maybe frequent follow-up and then ask them not to really go in for active passive smoking or any other risk factors. Other factors can also be done, Ki67, P53. This will show you what are the chances of recurrence. These factors also, you just have to ask your histopathologist, and these factors also you can get them done. What is our experience? Now the patients with leukoplakic patients, leukoplakia, which we have done IHC for, 7 of them have shown P53 positive, but there is no case which has really transformed into malignancy as yet. Now, as far as recurrence is concerned, for the malignancies, CNC2 well-differentiated carcinomas, amongst those patients who have shown positive P53, 4264, amongst these patients have shown recurrence. So I think there is some role, if the facility is available, to get done the IC for these patients to know about the recurrence and malignant transformation. You can just further go ahead and check if you can do IHC marking for your margins also. Why? Because we know there are negative margins of histopathology assumption, but still there is a recurrence which is seen. So it was a false negative. So to cut down this false negative again, you can do IHC for the margins also. So you can just check these factors in the margins and then know about again whether it's false negative or really there is some cancer which may come up for these patients. So you can do this molecular biology and these studies on margins also. And why they are false negative? Because residual tumor cells are not detectable in absence or through investigation. Then basically margins which are excised by laser, they are examined by the histopathology because they are very thin and they miss the tumor cells or they are lost actually because of the laser itself. So in summary, earlier we intervene, better the results for the patient, for his dysphonia, and of course, probable malignancy. Thank you.
Thank you. Thank you, Sachin, for an excellent presentation. I think we're running. Do we finish at 2:30, Sachin? At my time.
Yeah.
We have got 20 minutes
Uh,
more.
yeah, I think
There might
so
not
for
be enough
Rakesh,
time.
and we can
Hmm.
extend it for
Yeah.
yeah.
Okay. So Rakesh, can you put your presentation briefly? Might be some time,
Yeah.
5 minutes left for
Yeah.
question.
I
Yeah.
can't,
Thank you.
yeah, I may not be able to share my screen. So uh, you are not allowed. So please allow me to share my screen.
Yes, you can share your screen.
No, it is,
I'll ask Dinesh.
yeah, now I can see it. Yeah.
Okay.
Thank you.
Yes, it's seen now. Yes.
So in less than 15 minutes, I have to finish these topic on role of video stroboscopy already been covered. So I'll be focusing more on NBI and a little bit on more touch on eye scan and contact endoscopy. So I am Dr. Rakesh Srivastav. I am practicing in northern part of India. That is a capital of Uttar Pradesh, the largest state of India. So my area of focus is mainly the three part, that is NBI, eye scan and contact endoscopy, which has now been allotted to me. Laryngostroboscopy already been covered by Professor Sarah, so I will just skip on it. So why we are concentrating more on NBI? Because of this article which was been published and been accepted as a statement for NBI, that is for all treated patients and for early detection of cancer, NBI is a ideal tool of it. And for all part of treatment, that is by surgical or radiation or chemotherapy, NBI is being used as an integral part for looking at the residual disease or the recurrence of disease. So this is ELS recommendation for all treated patients. I have no disclosure, no conflict of interest, but I owe this presentation to my mentor and whom I not only think about is as a laryngologist, but he's a great thinker also, Professor Giorgio Paretti, whom I am been trained and he introduced to me this technology in 2012, and I started in 2014. So this is a new technology with 4K advantage. That is, it has been used for these following indications. But here my concentration mainly to the leukoplakia and dysplasia. That is, it has got a very high sensitivity and early detection of dysplasia is possible because of this contrast image enhancement technology. This is the classification which I follow in my practice. Though there are two types of classification. One is by Nee et al., which was published in 2011, and there was a ELS classification, which is given by European Laryngologic Society. So these are divided into various types, and from type 1 to type 4, it is type 3. These are the chronic laryngitis patients with early changes in the capillary structures, and then they start into breaking into type 4. That is a dysplasia part, and then type 5A, B, and C these are the malignant changes which we observe in narrowband imaging. So this is a pattern which has been described by Nee and et al., and it was quite impressive because I have done a 5-year study on this classification. Our publication is still waited to get it published. So pattern 1, 2, 3 is basically up to squamous hyperplasia, and type 4 is moderate to severe dysplasia, mild to moderate dysplasia, and type 5A is carcinoma in situ, that is high-grade dysplasia, and then type 5B and C are the squamous cell carcinomas. There is a ELS classification also which describes about the number of capillaries, the nature of the capillaries, how they look like, whether there is a convolution there or not. So they are divided into two parts. One is longitudinal, other is a perpendicular vessel arrangement. So the region of interest in narrowband imaging is intrapapillary capillary loops, which are the very finest end capillaries, 7 micron in size, and that is our area of interest. So whenever we are looking at a lesion, we have to look for these characteristics. in intrapapillary capillary loops. So these are the sizes, the capillary loops, they are very small, 7 micron in size. And perpendicular vessel changes, whenever we see a perpendicular vessel changes, that is abnormal loops or turning or wide angle loops or worm-like structures, these are indicative of either recurrent respiratory papillomatosis or squamous cell carcinoma. So there is a differentiating point, that is a gray area where there is some confusion with regarding the papilloma and squamous cell carcinoma. So these are the finer details which I think is beyond the scope of this lecture. I'm not covering that part of it. So what we define in NBI is what we label it as a near endoscopy. So near endoscopy, when we take the scope, a chip on tip scope at the very close range, the characteristics which we follow is on the lesion and around the lesion. So once we move the scope or hover the scope over the region of interest, so we can see there are changes which are there, which we follow it. These are the intrapapillary capillary loops, and there are brown dots are there around the lesion, which looks like a keratotic in the first image, but in the middle image, it is very clear that these are changes which is suggestive of type 5B pattern. So this is squamous cell carcinoma, and the margin you can see there are brown dots. So one lesion may have 2 pattern or maybe 3 pattern into it. So, but you have to look overall which is the highest in that ranking. That whether it is type 5B or whether it is type 4 or whether it's type 5A. So we look at the highest and we report it at the highest in the category of classifying by knee classification. So this is a lesion which I saw it on a buccal mucosa. This is a lesion which is seen as a brown dots, which are fine in, and they are at a very close range. Few of them are broader. So this is carcinoma in situ. And you look at the intramucosal cancer. So it can show the perpendicular vessel changes are there, which is indicative that the disease is also in the submucosa. So it is a disease of mucosa and submucosa, because NBI only tells about the mucosa and submucosa. Beyond it, it cannot go it, because it's a blue and the green light which we use it. Blue has got a lower wavelength and green has got a higher wavelength. And by their characteristics on reflection, they give the blue light gives a brown color, while the green light gives a cyan color. So we look into these patterns, and one by one I will cover it. That is type 2 pattern. This is especially seen when the patient starts smoking and he has these changes and finer vessels which are coming from the lateral part of the vocal folds. So type 3 pattern is umbrella effect, we call it, because it's the hyperplasia. You are seeing it, a leukoplakic patch, but there is a vessel which is coming from the side. So this is squamous cell hyperplasia and mild dysplasia. Then again, focusing on the same type of lesion, which looks like on NBI, it's a leukoplakic patch with mild to. And now again, we are going to the deeper part of it, that is a white raised lesion, which is multicentric. And on NBI, it is showing across both the cords and on the right side. So these are umbrella lesions, and whenever we are looking at the umbrella lesion, that is a white lesion, we have to look at the margin of the lesion, because sometimes we encounter some changes which are there. Now here also, if you see here this type of lesion, and there again you see on this type, on the left cord, you can see there are brown dots are there. And these are finer dots which are indicative of moderate dysplasia. So here you can see the capillaries which are breaking off, and there is a white patch is there. So we report separately that is right cord has got this type of pattern and left cord has got the other type of pattern, and then we correlate with histopathology. So we have studied around 107 histopathological specimen comparing both the cords and unilateral cords. So this is again a varicose type of growth, which doesn't show any features which are in the adjacent part of the lesion, which are indicative of malignancy. So these are similar type of lesions which we are discussing for past 1 hour, that is leukoplakia. Now coming to the another interesting case of this case was operated for right quad. Then again, it presented with a white lesion again, inflamed lesion on the left quad. But once we got very close to the lesion, we can see there is a spine brownish dots are there on the left quad, which is indicative of moderate dysplasia. So early detection is possible with NBI. It is a technique and the tricks which we have to use it, and we have to go as close to the lesion so as to look at the. And here also, if you see it here, the capillaries are breaking out, and there are small brown dots are there, which are very clearly seen from adjacent to the white patch. So this is again indicative of moderate dysplasia. And again, this technology can be used in peroperative assessment. This patient presented with the right quad lesion. And because we have used NBI, use both the NBI in office in OR also. So we will be able to see in office, then again we are assessing it in operating room to know the extent. But here we, in pre-operative, we reported only on one quad, but once we gone close to the lesion, we can see there is a small subtle changes on the other quad also. So there is upstaging of the disease. It was T1A pre-operative, but on peroperative, there is a change to it. Then again, this is type 4 pattern, which is classically seen in moderate dysplasia. And these are the brown dots, which we are seeing it, fine brown dots with a raised lesion like this. So sometimes we get this type of localized lesion, which are doesn't look like carcinoma and C2 on knee classification, but they came out to be on histopathology, it came out to be CIS. So there are false positive, false negative. And type 5A pattern, we are seeing a brown dots, bigger dots, which are widely scattered. And this is indicative of malignancy. Here also, if you see it here, there are two patterns. One is slough covered growth, and there are brown dots are there, which is indicative of moderate to severe dysplasia. So one lesion might have 2 or 3 patterns into it, but we have to report it to the highest grade of which we see on knee classification. And these are typical snake or earthworm-like structures we see on right arytenoids, which are indicative of invasive cancer. This is again a tadpole-like or wire loop pattern, which are classically seen in squamous cell carcinoma. So one lesion may have a multiple pattern. Reporting is according to the highest pattern. This is type C pattern. Type C, when there is a slough formation and there is a only few vessel you can see it in the lesion or around the lesion. So there is another article which was been published by Ni et al. In 2018, in which he has covered 120 cases of leukoplakia and 81 were benign. And he has done a histopathological correlation with it into it. But it was reported by 2 experienced endoscopists of more than 3 year experience. And what he has found is accuracy of NBI in leukoplakia is 90% as compared to white light, which was 70%. But here in the paper, he has not mentioned about the pathologist, because we were discussing, Dr. Gandhi was also telling about the reporting. If there are 2 experienced pathologists, or if there is a one lesser experienced pathologist, will have a different type of reports in moderate to severe dysplasia. There's some variation will be there. So pathologist report is also very, when you are comparing it, or a single pathologist who has an experience of 10 years dealing with all the laser specimen, he can report or she can report in a better way as compared to the less experienced pathologist. So he has again divided this into leukoplakia into different categories. And what he has described is type 4, 5, and 6 as a malignant white patch. Almost the same classification which we followed in the first classification. But only thing what he has added is there is a white lesion with a raised margin, with a roughened margin, will have a more chances of malignancy as compared to the lesion. White flat lesion will have a less chances of malignant changes. So coming to the limitation of NBI, it has a false positive and false negative are there. Difficulties after dissection of tumor, mainly the depth of invasion, which is possible with the stroboscopy, because stroboscopy mucosal wave you can appreciate. Learning curve is always be there. Stagnant saliva, sticky mucus, especially in CTRT patients, are difficult. And lesions like umbrella lesions or hyperkeratotic lesions sometimes prevent visualization of mucosal vessel. This is my book, which was published. We are coming up with the second edition of this book. So this will cover mainly the other technology and granulomatous lesion, which we see in this part of the world. So upstaging of tumor, we can use it for NBI. I have 2-3 publication also. One is on narrowband imaging in chronic granulomatous disease, that is laryngeal tuberculosis. And there is another article which compare the upstaging of tumor in preoperative and post-operative preoperative and the peroperative early clotic cancers. So there was a definite upstaging which we have observed in this study. I'm just skipping this. Stroboscopy covered by Dr. Sara. So this study was meta-analysis of 5 studies which she has included. And STOPE can identify almost all patients with cancer, but only approximately 2/3 of patients with non-invasive lesions are correctly identified as not having cancer. So we are still discussing about the normal laryngeal stroboscopy result predict the absence of invasive carcinoma. So absence of mucosal wave is indicative that there is a invasion of, because according to the body cover theory of concept of vocal cord anatomy, we can say about whether the invasion is there or not. Now, coming to briefly about contact endoscopy, which I have not been doing it, but because Dr. Gandhi has said you cover it. So it is a non-invasive optical image enhancement technology, and in this we use a vivo technique. This technology also depends on the person-to-person experience also. So there are 3 mainly dyes which we use, staining the superficial layer of superficial lamina propria, and it can see only the mucosal lesion only by looking at the hyperchromatism, nuclear cytoplasmic ratio, mitotic figures, and vessel arrangement. And normally we use a Rod-Hopkins scope at a very close range. And normally we can use a 4K scope with a 50x or a 160x magnification. So as the magnification increase, the size of the assessment will be less. So it is a very cumbersome process and it requires a lot of training for it. And but though it is a good technique to use it for a very small lesion. So normal vocal fold look like this with the capillaries here, and now here you can see the capillaries are breaking down, and there are few NC the nuclear cytoplasmic cells disturbance is also there. You can see it in that picture. So there are various dyes are used. One is this thing, acriflavin is also being used. Acriflavin is good for nuclear structures. And this is ALA is used to look for the fluorescence. And for orange red, if the fluorescence is there, that is indicative of neoplastic cells. So limitation of this contact endoscopy, it has a poor penetration and it requires high magnification. But the depth is very less, 80 micron if you are using 60x magnification. Now a little bit I touch upon the eye scan. So eye scan is also a post-capture enhancement technology which has been introduced by Pentex. And there are many comparative studies which support that eye scan is equivalent to NBI. So, but NBI is based on neoangiogenesis, and NBI is basically a analog test. It is not dependent on the contrast enhancement, because in eye scan we use a surface enhancement, we use contrast enhancement and tone enhancement. So tone enhancement is basically used to look at the capillaries, contrast in the surface enhancement and look for the mucosa. So I'll just show you that how the surface enhancement is done. So this is a white light image, and the surface enhancement, you can see there is the contrast has improved and the surface is more enhanced as compared to this where the image is very hazy on the left side. Contrast enhancement, again, it raises the blue signal of the capillaries and it will show clearly the capillary arrangement of the. So vascular pattern, you can see it better with the tone enhancement of Pentex eye scan. Eye scan can also be used when the blood or fecus is also there, but NBI is ineffective when the blood is there. So this is a study which almost compared the narrowband imaging with the Strauss Professional Image Enhancement Technology, that is SPICE, and they have found is the results of SPICE camera, which is used by Callisto, that there are 5 modes are there in that: Clara, Spectra, and there are 3 modes also. There's one is combined Clara and Chroma. So that technology is also a post-capture enhancement technology. And they have compared both the technology as such, but the problem with this study was, what I have observed is, the limitation is high definition NBI was used pre-operatively under local anesthesia, and SPICE was used in intraoperative under general anesthesia. And this has been observed by Dr. Piazza also, that the assessment is better under general anesthesia once you are using a technology, and pre-operative, when you are using under local anesthesia, you may miss out some finding. And the more the pixel will be there, if you are going very close to it, rod lens will give a better picture as compared to the chip on tip camera scope. So again, there is another study which compares both these technology, but we are not aware of this Xeon professional image, and they have also reported the same amplification post-capture enhancement technology as compared to NBI. Again, the same problem was there in this study also. Image enhancement technology used before the surgery, while image 1S was used during the time of surgery.
Rakesh, we are
Yes.
nearly
Yeah,
reaching 90 minutes that were given by
yeah.
Sachin Gant to
I'll
us.
just
So
I'll just finish off with this, my study. That is, our study also correlated with mild, moderate, and severe dysplasia. But here what we have seen is moderate and severe was sometimes difficult to differentiate using NBI technology. Because of early part of my career, I was not able to differentiate it. So to conclude is, high definition and contrast image enhancement technology have changed the management concept for pre-malignant and malignant glottic lesions. The concept of single-stage transforal laser surgery was introduced by Blaxley and Paretti in a selected glottic cancer. This is what we also follow it. I also follow it in my, that is mid-cord growth. We don't go for any, we use this technology. Interpretation of these lesions depends on endoscopist experience. False positive, false negative is still a concern in country like India, where the granulomatous laryngeal tuberculosis is high. A limited surgical excision with voice conservative TLM is possible due to these technologies. Thank you very much.
thank you, Sachin. We need to ask you about the time
Yes,
that
sir.
we have
No, we can
available.
we'll extend till 15 minutes more now.
Okay. Now,
And
can I ask you, have you got any questions from the audience? We give preference to questions from audience.
yeah, I think one thing is any preventive measure, a medical line of treatment or surgical line of treatment. And somebody asked us whether vitamin A can be used as a preventive. So I would just like to tell to this particular question, we are giving, and the literature says folic acid supplements can be used for leukoplakic patches, which on examination and our clinical judgment doesn't look as malignant. So I think vitamin A doesn't have any studies published as yet, but yes, folic acid does have. Other questions really have been discussed. How you distinguish between keratosis, leukoplakia, scheme of leukoplakia to prevent recurrence, and how PETs can help in a follow-up. I think these points have been discussed. And I think as far as prevention is concerned, basically cessation of tobacco consumption, cessation of alcohol, lifestyle modification, high dosage of vitamins, including folic acid, And there are some studies which are published from Chinese and they have tried some local medicine which can be used to really treat and prevent the this one. So it's a 400 milligrams of folic acid once a day for 6 months. So the paper says 58% complete remission and 28% of partial regression of leukoplakia patches. These are the two studies. So it's the high meaning. So I think again the examination and clinical judgment of leukoplakia being non-malignant, you can always try folic acid or other vitamins to really treat it firstly.
Hey, Brandon, have you any comments on those topics?
I don't have much experience with folic acid. I've seen some other vitamin supplementation, introduced in literature like vitamin A and whatnot, but I'm not sure I have as much experience with that, and I'm not sure if there's been good placebo, controlled randomized trials for that yet. So I think for me, jury's still out in terms of that, but I agree wholeheartedly with what Dr. Gandhi is saying about smoking cessation and alcohol, avoidance, hydration, those types of things for prevention, I think are helpful. And I find that for my patients that continue smoking after treatment, even with mild dysplasia or moderate dysplasia, they have a higher recurrence rate if they continue to engage in those behaviors after treatment than those that abstain.
Okay, Rakesh, is he gone? And Sarah is there still? They're not there now.
Yes,
Oh,
I'm
Sarah.
here.
Yeah, any comments on questions?
I think we have to definitely encourage what we know to be data-driven and true, like Dr. Baird was saying. So the risk factors that we are aware of, smoking cessation, alcohol use, various inhalants, those really need to be avoided. I think we're also still learning. So the patients who are willing to take these extra steps and share with us what they're doing, and we can monitor the outcomes, and that can really guide what we choose to study. I think, we can use our patients as our inspiration for what we study, analyze, and then hopefully use down the line to advise patients. So I certainly don't discourage this use of the supplements. I don't think it's harmful as far as I know. So I'm curious, to keep this conversation going, to learn what you observe with your patients who do take these supplements. It's not something commonly that I advise, but mainly because I'm focusing on these other modifiable risk factors that are so hard to implement for patients who have these habits. And so, I really just try to encourage patients, even just reduction of smoking is helpful. That maybe it's not about cutting it out completely, which can be very overwhelming and daunting, but reduction, and encouraging that, helping them see that that's possible, and then go on from there. So, but I don't think any of these are bad ideas. In fact, I'm curious to hear what everyone else's experiences are.
They say wherever there are many ways, none of them is certain. So
I would like to add three things. In my all patient, especially the female patient who present with dysplasias or leukoplakia. So one is in our part of the world, we have this laryngopharyngeal reflux is very high. So I usually add on alginate and PPIs for a long term. And sometime I shift it to famotidine also. And second thing I add on is curcumin, which is curcumin is basically anti-carcinogenic, anti-fibrotic. So we give it for a longer duration of time, and especially patients who are non-smokers and who have no prior history of any exposure to pollutants. But since we are seeing 20 or 30% patients who are non-smokers who have got this type of lesions. So laryngopharyngeal reflux is one of the reason for it. Another is pollution. The AQI is very high in the northern part of India. We are almost facing more than 300 above scores in air quality index. So that is another factor for it. Almost every individual is smoking 20 cigarettes a day in this part of the world.
Okay, thank you, Sachin. Any other questions?
I think it's nothing,
No. Well, then I would say concluding remarks.
sir,
I think the
should I-
presentation really,
should I announce the
Sorry?
next session?
yeah, well,
Yeah.
say you in second.
Next
Or you
session,
do that first. You
Yeah.
do that first.
yeah, next session is on 17th of August. And it's on early glottic CA. So diagnosis and management.
Okay. The 17th of August.
Yeah.
That's a Saturday, of course.
Yes.
Yeah. The unusual time.
Yes, yes, yes.
Okay. Thank you. I think my concluding remarks would be the presentation has been from the basic laryngoscopic examination all the way to research of very high quality, high degree research, which is still in the realms of research and not really practical for any doctor who is practicing laryngology in a private practice, small private practice. I think I picked up 2 or 3 important messages for global audience that we have here. The basic importance is to differentiate between stages of dysplasia. Leukoplakia is a clinical visual diagnosis. Dysplasia is pathological diagnosis. And I think one should go for pathological diagnosis in order to have the management. The next issue that I picked up is there is a range of dysplasia within the given lesion. Some are more advanced than others. And I didn't quite get the message from anybody. How do you pick up during one particular lesion which one to biopsy? Excision biopsy, of course, is good. But if you have to biopsy, how do you pick up that particular lesion? Now that we might have gone some way further with the eye scan, for example, to have the excessive blood supply to a particular part of the lesion indicating more activity, maybe, but that's a research tool. So that's second point that is very much of a what you feel, where you take a biopsy from. And the third point, I think, is you have a diagnosis of grade 2 or say stage 2 dysplasia. Stage 3, you go further and say it's carcinoma in situ. So at that particular stage 3 dysplasia, do you treat that as carcinoma in situ? Anything from, yeah? It
Yes,
is
I do, yeah.
carcinoma in situ, is it?
Yeah,
yes.
I do.
So high grade
I-
dysplasia and
I was-
too. The principle of treatment is same. Yeah.
So if it's carcinoma in situ, when do you think it will go into carcinoma, frank carcinoma? Does it go into frank carcinoma? Of course, it goes in frank carcinoma in some cases. But how do you tell your pathologist that, look, this is great, stage 3. Now tell me more about it. Is there anything further you can tell me so that we can treat this as cancer and not carcinoma in situ?
Everyone's variable. People present in various ways, and people will have a pattern of recurrent, dysplasia that tends to look like leukoplakia, and then suddenly it'll transform into a more like erythroplakic lesion, and that tells you sort of something's going on, that may be progression of disease, or you'll notice maybe some change in stroboscopic properties that tells you maybe there's something a little bit more concerning going on. The only way for you to know is just biopsy it. So
carcinoma in situ, not every case goes to cancer. No, it doesn't.
Not necessarily.
I've had patients that don't progress, that just continue to grow carcinoma in situ.
I always believe that carcinoma in situ is an entity rather than definite precursor of cancer. Yeah. So when do you stop getting biopsy, repetitive biopsy in carcinoma in situ? And what will be your definitive treatment for carcinoma in situ and not cancer just yet? Anyone?
Yeah.
Go ahead.
I mean, if it is, a single lesion, then of course, follow up and type 1 correctomy So some mucosal choroidectomy, and if it is multicentric, then patient has to go for radiation.
But multicentric is a different entity altogether. I think it's not common either.
Yeah, but
So
it's, yeah,
multicentric means several places
yeah,
have the same lesion.
yes,
That's
yes,
what you call multicentric, because multicentric disease can be different altogether.
yes.
But multicentric means there are more foci in the same lesion.
Yes, yes.
Then that becomes extensive rather than multicentric. What do you think? I mean, semantics. I don't know. Multicentric is a word where I would use that there are more different types of organs are involved, which
Not
are
really.
giving,
Uh,
or multifocal,
multifocal, yeah. Multifocal would be a better term, yeah.
multifocal.
Yeah.
So if it's multifocal, there's no question that it's unstable. Mucosa is unstable everywhere. That's why it's multifocal. Because dysplasia means it's not normal. This means it's not normal. And once you get dysplasia, it's not normal. Then what is it? Is it carcinoma in situ or cancer? That's what we're talking about. If it's carcinoma in situ, then abnormality can be multicentric, of course, in the same lesion. So if you got carcinoma in situ, how far would you go? By doing choroidectomy? Would you give radiotherapy for carcinoma in situ? We used to in old days.
Not
I try to avoid it if I can. If I can treat it all endoscopically, it's my preference.
I
Sarah?
think again, it would go to my patient would go to Sarah, because these patients, you do a biopsy, and after excision they come with a histopathological report of carcinoma in situ. Now, whether to go in for another surgery to take the margins or not is a very tricky question.
Yeah, I know.
What we do, and we do their stroboscopy on follow-up and just check if the healing is good, because carcinoma in situ, the treatment is just pluck it out because it's in situ and you have removed it. So there is no need to go in for another surgery to check the margins. Just keep under follow-up with a stroboscopy, and then as soon as you get some doubt, again you can go in for a margin. And with PET scan coming in, you can do a PET scan maybe after the year, or when you have got a doubt, or when the patient is additionally exposed to tobacco consumption, any type of tobacco consumption.
Yes, I think all the experts that sitting here, they all, of course, have institutional attachments, and they've got a hell of a lot of instrumentation and everything else, the sophisticated ways of saying what you're saying. I think in more practical terms, if you've got carcinoma in situ, you then follow up with biopsy, or I will ask Sarah, how much of your stroboscopy would give you indication for you that have carcinoma in situ should have the next biopsy?
Yeah, I mean, sorry, I'm here with my daughter. It's 2.5. I think that if someone could tell how to manage carcinoma in situ just from appearance, we would be having a very different presentation today. It's hard. It's really hard. That's why it's helpful to know your patients, track them over time, and have documented serial exams, so that if there are subtle changes between, every 6 months or every 3 months or however often you're monitoring them, voice alone in a situation like that for carcinoma in situ really might not be a good guide for how someone's disease is changing. So I think in a case like that, close observation, serial observation, recording the exams and being able to compare them can be very helpful. But I think in a patient like that, eventually you're going back to the operating room. The nice thing is that if you know that they had carcinoma in situ before, if their exam has generally not changed in terms of stroboscopic findings, you might be able to avoid rebiopsying them. And you can really just use the laser to ablate the lesions that are there, which ultimately, obviously a biopsy is critical because you can't treat someone without a diagnosis, but A biopsy can also be destructive, more destructive than a laser, let's say, because you know that the
Okay.
CO2 laser, a single pass is going to be 250 microns. You know, this squamous epithelium is 500 microns thick. If you can avoid ablating the surface of the squamous epithelium, you're doing your patient a service. That
Thank
can be
you.
hard, obviously, with carcinoma in situ, but that's
Thank
my
you.
thought.
Thank
Yeah.
you very much. I think we're nearly there. You raised the non-medical point there, of course, Sarah. It's a 3 months or 6 months. And, when I was doing surgery or my clinics, I got a message once from registration. He's like, Mr. Oswald, can you make it 5 months, please? Because 6 months are full, 3 months are full. All doctors are oriented for review examination for 3 months, 6 months, 9 months, and a year. They never have 2 months, or 2 months they have, but never 4 months, never 5 months, never 7 months, never 8 months. What a wonderful observation that we have. Anyway, Sachin, can we conclude?
Yes.
Well, again, thank you very much for a most wide coverage of this difficult topic. I hope one day we will get rid of this leukoplakia name and call it what it is, dysplasia, because leukoplakia has no meaning whatsoever. And we again thank you for the global audience, who I'm sure would find some points useful, other points academic, and some points beyond the scope of their practice. Nevertheless, thank you for your attendance. Thank you for excellent presentation. Thank you.
Thank you so much.
Thank you.
Bye. We'll see you next time. Okay. Thank you.
Thank
Bye.
you.